So welcome everyone to our exciting and informative speaker series event today. Thank you all so much for attending. We have the privilege of hosting Professor Kenneth Hillman from the University of New South Wales. We thank him sincerely for his time, insights, and for joining us today. We'd also like to take a moment to acknowledge the Palawa Pakana people as the original custodians of the Lutruwita, Tasmania. At Palliative Care Tasmania, we acknowledge the Palawa people's deep connection to family and community and their enduring strength and compassion in caring for sick, dying, and grieving. I would also like to pay my deepest respects to their elders past and present and extend that respect to any Aboriginal or Torres Strait Islander people who may be joining us today. We will have 15 minutes at the end of the presentation for questions. If you have questions during the talk, you can submit these via the Q&A function, which you can find at the bottom of your screen. We also have the pleasure of giving away one free copy of Professor Hillman's book, A Good Life to the End. Please visit Palliative Care Tasmania's Facebook page at the end of today's session, where we'll be announcing the winner, and the winner will also be contacted via email. It is with my pleasure to introduce Kenneth Hillman, a distinguished professor of intensive care at the University of New South Wales. Professor Hillman graduated from Sydney University and completed his training at St Vincent's in Sydney and St Bartholomew's Hospital in London. As one of the first formally trained intensive care specialists, he served as the Director of Intensive Care at the Charing Cross Hospital in London before returning to Australia to become a director at the Liverpool Hospital in Sydney. Throughout his career, Professor Hillman has made significant contributions to the field of intensive care medicine. He's published over 210 peer-reviewed articles, contributed approximately 90 chapters in textbooks, co-authored an intensive care textbook, and co-edited several others. Additionally, he has written 2 books aimed at the general public and secured $23 million in peer-reviewed grants. His expertise is widely recognised, as evidenced by his invitations to speak to over 130 international conferences and more than 140 national conferences. He's held numerous professional positions in healthcare and is the director of Simpson Centre for Health Services Research. In his recognition of outstanding contribution, he has been awarded the Order of Australia. He's also well known for his work on end-of-life care and has delivered a TEDx talk at the Sydney Opera House on this important subject. Please join me in welcoming Professor Ken Hillman.
Fantastic. Thank you very much, Luke. Good morning, everyone. Can you all hear me? Am I okay, Luke? Good.
Yeah, very clear.
Thank you very much. Look, I'd like to start off with this statement, and it's really, like I guess it's a theme of the whole talk really, is that the current fallback position for the elderly frail towards the end of life, i.e. maybe within 12 months, who suffer acute deterioration is hospitalisation, not palliative care. And I find that quite amazing and probably unacceptable. So what happens, how did this happen? Because these people see a lot of health silos along the way. They're community services, general practitioners, residential aged care facilities, allied health. But then if they fall over or if they get an infection at home, then we call an ambulance. Now, that's a logical response. The ambulance has no discretionary power but to take the person into the hospital. They're seen in ED. ED hasn't got time to conduct these complex discussions about end of life and what people want. So into hospitals they come. And then working in intensive care, I see a lot of these people who probably shouldn't be there because there's not much we can do, one, but secondly, most people do not want to die in a hospital. So no part of the health system recognises them as being terminally ill. Now, this is strange because palliative care has done marvellous work, for example, with cancer, and we all use the word terminally ill. But if you've got data that recognises an elderly person as being in the last 12 months of life, we don't use that word terminally ill. Somehow they're treated differently. So who owns these elderly frail people near the end of life? That's the problem, because while many specialties, while many medical specialties sort of encounter these people, no one really owns them. Geriatrics, palliative care usually has to have a referral. Then there are hospital specialists. Now, bless their hearts, these people are excellent with one organ, with one system, and with one problem. But they're not usually that good with elderly people with multiple problems. GPs are sort of excluded from the system, and that's for many reasons. So who owns them at the moment? Maybe we can safely say that no one in particular owns these people. And most are not diagnosed as being terminally ill until just before death. So, for example, we have arguments in hospitals, I'm sure many of you have seen this, whether we deliver CPR with a 95-year-old person towards the end of life. And there's what happens when people, just before they have a cardiac arrest, what happens when they deteriorate. And I'll come to that in a minute. And they're seen in ED, they're seen in ICU. We sort of know that they're terminally ill, but they're on this conveyor belt. So we're sort of paralyzed and don't do much about it. Now, I find this another amazing article. We set up a emergency response system, a MET system, or whatever you want to call it. It's in Tasmania, and it's in every hospital across Australia and indeed in many parts in the world. So we did a large study soon after we set it up, and we found that 1/3 of all emergency calls in hospitals are for elderly people near the end of life. In our state, New South Wales alone, that's about 40,000 patients per year that aren't recognised as being near the end of life. That is, within hours or days sometimes, until they're just about to have a cardiac arrest. So this is data from my own hospital, and I found this really quite extraordinary. It's not surprising that 4C is the palliative care ward, and they have the most deaths. That's not surprising. But look who comes second, intensive care, 258 people per year who die in intensive care. Most of them are expected. Most of them are at the end of the conveyor belt. And similarly with ED is up there as well. So they don't die normally in the hospital wards. They die in palliative care, ED, or ICU. So what happens proximal to that point? And that's, again, coming back to this fallback position for the elderly frail, in that it's not until they reach emergency departments or ICUs that we actually recognise and start to label these people as being terminally ill. And the whole irony is that almost all elderly people in Australia do not want to be hospitalised for dying. So this problem is not going to go away. As the ageing population increases, we'll find more and more elderly people surviving, and they survive with increasing frailty, increasing comorbidities, and decreasing lifespan, obviously. So healthy aging, I get a bit worried about this term healthy aging. I've got no problems with good diet, exercise, and all that sort of thing. But as we get older, we come closer to being at the end of life. And I like this term apoptosis. It means that conception is embedded when all your tissues and organs are going to start aging. And it's different in all of us. When your skin starts getting wrinkly, hair starts getting grayer, and all those aging accompaniments. Now, of course, lifestyle determines that as well. So you may have an apoptotic potential of, say, 100, but if you do a lot of bad things in your life, you're not going to reach that apoptotic potential. However, as you all know, aging is inevitable and incurable. So patient safety in hospitals, and we've all grown up, those of us who work in hospitals, with stopping people dying. That was how we measured how good we were as a hospital, how good we were as clinicians. And we're still obsessed with this, sort of using death as the worst thing that can happen. And that makes all the things that we're talking about in palliative care even harder to reverse. So there's all these systems to look at people that die. And so, for example, IMS or patient complaints, infection rates, but I'm very interested in morbidity and mortality meetings These are in hospitals all around the world, and they're looking at people who suffered severe morbidity or mortality and finding out what went wrong. Now, another way of looking at this is, should we be measuring the safe management of end of life rather than seeing what went wrong? Because most of these people die a very normal and predictable death. So the factors that contribute, and I've got a long list of these, but I'm sure you're all familiar with it. As healthcare professionals, we're programmed to cure. It's just embedded in our DNA. This meets up with societal expectations towards optimism, emphasis on medical miracles. We don't like talking about aging and death. So this is a powerful complicity, a healthcare program to cure you and a society that doesn't like talking about death and dying. So this leads to this surreal, extraordinary crisis that our hospitals are overwhelmed by a population who would prefer not to be there, and where the hospital has little to offer anyway. When people have these chronic diseases, they're not amenable to all the medical miracles that we do in hospitals. So where next? Elderly people are not children. They don't want to be patronized. They want to hear the truth, and they want to be involved in their own life. These are plain things that we can't argue with, but we don't normally comply with what elderly people want necessarily. So we've got all this data about how bad the situation is, but what do we do about it? So the system for managing end of life, and here I'm mainly talking about the elderly frail, is to go back and identify the people. Well, we've got lots and lots of data where we're able to do that. Once we've identified them, then we need to respond appropriately. So we need to figure out who's at risk of dying within 12 months. As I said, heaps and heaps of data, and the appropriate response must be person-centered. And I know everyone says this, but it's often very rare that we do this. We tend to inflict our own health perspective on people rather than listening carefully to what they want. So designing a health system for the elderly, it needs to be a whole of health and society system. And one of the problems in the past is that we work in silos, GPs, community health, EDs, ICUs, whatever, and it's really hard to work across these silos. Silos work really well to do what they're meant to be doing, but they're not very good at working between each other. So we need to turn this around, I guess, and design a system around the patient and their journey. Identifying elderly frail people near the end of life. Well, some people already do this. For example, why can't people over the age of 78 years of age get funeral insurance? Why is it almost impossible to get travel insurance? Sorry, that should be insurance when you're more than 84 years of age. So some people have done the data. They've looked at this really carefully, and they know the risks. They've done it much better than health. Residential people in aged care facilities, that's where many Australians go to die. We don't like to talk about this, but it's a fact. 70% approximately die within 1 year. Almost all of them are measurably frail when they come into their the residential aged care facilities. Now, there's a thing called the geriatric syndrome. I hope there aren't any geriatricians out there. And if there are, I'll have to be generous with what I'm about to say, because this is the gold standard, I guess, for figuring out what are the problems as people get older and what we should do about it. Now, there's one very important bit of predictable complication that's not there: dying. Now, of all the people in the world, it should be the geriatricians who can help us with this, who include dying, end of life on that list, and help us with what to do about it. We've actually done this work ourselves. We've we've sort of published a lot on very complex ways of trying to figure out which people have got less than 12 months to live. And I must say that it was a bit theoretical and probably too complex. And there are much simpler ways of doing it. For example, the surprise question developed by UCH Hospital in London. So a health professional looks at an elderly person and asks themselves, would I be surprised if this person dies within 12 months? And it's amazing how accurate this one simple question is. Frailty, I really love this word, and I've come to embrace it as a way of summarizing all the multi-organ chronic health problems that go along with aging. It's a holistic view of patients, not based on age alone. Some people get frail early and some people get frail later. But it's a word that can be used by people, by society, as well as by doctors, and we're beginning to put numbers on it. So we can talk to each other, health professionals and people, patients, can talk to each other using this one beautiful word. And there's about 40 different ways of measuring frailty. However, I really like this one developed by Rockwood, who's a physician in Canada. And I remember the name Rockwood because it sounds like Rookwood, which is the largest cemetery in Sydney. And it's a very simple way of classifying frailty. One, you're very fit, normal, and then there's all these pictures showing how people become more and more vulnerable and more frail as they get older. Until 8, they're bedbound, very severely frail. And then you've got 9, which no one really understands. Rockwood put it there because he didn't know how to include people, for example, with metastatic cancer who are also dying. I think it's best to forget number 9. So frailty leads to increasing disability, falls, admissions to hospital, long-term care, and death. It's very common in hospitals. It's about 42% in people more than 65. Half of all elective surgery are frail. 80% of medical patients are frail, and 100% of geriatric patients are frail. So what's being done? We've got things like NFR when people come into hospital. Bearing in mind that if you're old and have a cardiac arrest, you're rarely going to be able to be resuscitated anyway. Advanced care directives, advanced care planning is a great start, but it's got very limited penetration in Australia so far. So identifying older people near the end of life in EDs, this is some of the work we've done. We did this 5 countries, 12 hospitals, 3,000 patients, and it did not work. It was too late. These people are too old and too sick to be involved with complex discussions about end of life. So that was a total failure of research. Then we went to the general practitioners, thinking that if we get them much earlier, that would be much better. Again, this was a total failure, because general practitioners are not reimbursed. They're a small business. And so to have complex, long discussions with older people, they're not reimbursed. And so that's a system failure. It's not a GP failure. It's a failure in the system. So then we came back into hospitals and we did this large study in Queensland where we identified every 75-year-old in 3 big teaching hospitals in Sydney, and we had an army of nursing staff who told the admitting team when they were near the end of life, thinking that then the admitting team would do something different, like refer them to palliative care or discuss with the patient or not have them admitted to ICU or whatever. It was a good trial in that it was a randomized controlled trial, big study. And so we had the controls where we did nothing, and we had the intervention where we told the admitting team, you have got an elderly frail person near the end of life. What happened? the controls did better. So working through admitting teams doesn't seem to be such a good idea, or maybe it was just the way we did it. However, we put a lot of money and a lot of effort. Nothing happened. So where to next? It's obviously about building the system around the person. So this is probably very obvious to most of you, but it's not obvious to a lot of healthcare people like myself, in that the priorities for the elderly nearing the end of life are not medical. The top 10 are not medical. They're things like loneliness, a sense of worth, social and community fireworks, home cleaning, personal cleaning, shopping, stuff like that. And how to incorporate that into a bigger picture of palliative care. You probably all know this, but it's news to most specialized physicians. I like this word almost as much as frailty, shared decision making. So it's more than advanced care directives. It's trying to achieve genuine equality. Who exactly is this person? So you have long discussions and establish what are the things they like, what are the things they don't like, and then to translate that into goals of care. It takes training, it takes a couple of hours, but you really get to understand who the person is. It's not a tick box like advanced care directives. Then this needs to be communicated through the whole health system. That's not happening. I'm just saying it does need to be communicated. And it's probably not just for aged care near the end of life. If we did this properly, this could become one of the most important documents in healthcare, who the person is, and designing any healthcare intervention around that. So the response, a healthcare professional with appropriate skills, knowledge, experience, training, and time, and many of you have already got that. The more I work in this field, the more I'm thinking that we need a navigator, because it's all right to say what you want, but then when the time comes when you're starting to get sicker and nearer the end of life, then you're confronted by a very complex health system. And more and more, I'm beginning to believe that you need someone to help, someone to support you through this system. A bit like the wonderful system that's been set up with women with breast cancer in country areas, where they have a navigator to guide them through, the surgery, the chemotherapy, the traveling to the centres, the respite care, all of those sorts of stuff. And I'm thinking that to have a really good system, we need that. So people are empowered to determine their own goals of care. This is communicated and complied with across the whole system. And then we need a response. And I'm beginning to believe that a navigator is really important in this area. People have the right to know that they're terminally ill. Sounds like it's such an obvious statement, but we don't do this at the moment for the elderly frail. They've also got the right to determine their own goals of care. So, for example, the Queen, this was a great death. She was getting noticeably frailer. As she's walking out on that balcony in Buckingham Palace, I was measuring her frailty, and it went from 4 to 5 to 6 to 7. You can actually see it. And towards the end, she only stayed there for a couple of minutes, then had to be helped back in and sat down. And interestingly, she was allowed to die of old age. That was on the medical certificate. We are not allowed to do that in Australia. And so we have to make up something. We have to say something like cardiovascular disease because you can't die, you can't live without your heart going. We have to make up things. And this means that 70% of Australians die of cardiovascular failure, which means that all of our research money goes to cardiovascular research, not to palliative care. Yeah. So I like this phrase as well, petit mort, which is a French phrase. It means that when you're dying of old age, you become terminally ill in bits and pieces. So you slowly lose sight, hearing, taste, muscle strength. balance, cerebral function, organ function. So this is sort of different in ways that you people understand better than I would from cancer. And it probably needs to come under palliative care. So I can recommend this article. It was a beautiful article, and it's about bringing the value of death back into life. It's a superb article, published last year, January the 22nd. And you all know this, that medicalization of dying is not good. Dying is a societal event with a small medical component. And that's something that I've learned over many years coming from a very medical perspective. So how do we integrate palliative care into the care of the terminally ill elderly people? You would know more about how to do this than I would. And finally, I'll leave you with this slide. It's one of about 4 or 5 that I've got of elderly people in intensive care on ventilators. And this states in very wriggly writing, I want to die, please. And please give me water. I'd like to stop there. Thank you very much. And I'll just stop sharing, Luke.
Thank you so much, Ken. That was really informative, engaging, and I definitely took away a lot from that. So that was wonderful. Thank you for your time. We've got some questions, so I might open up the Q&A session now. So if anyone does have any questions, you can just pop those into the Q&A function, which is just found at the bottom of your screen. We'll try and answer them all today if we've got enough time. So I'll just pop that open and have a quick look. So we've got one question here. Ken, you mentioned a navigator. Do you see that person having a medical background?
Look, the more I think about this, the more I think that person needs to know something about the health system. It certainly doesn't have to be a doctor. And I think many palliative care nurses, particularly in rural areas, are doing this anyway. So so I think a nurse would be ideal.
Yeah. Yeah. There's a follow-up question along that. So it sort of ties into it. Who do you suggest the navigators to be, such as social workers, or is it someone that works in the palliative care as a palliative care nurse or something like that?
Yeah, look. I mean, I think a palliative care nurse would be ideal because they know the system. They're not afraid to talk about death and dying, and they could take on this role a lot more. Many of you are probably doing it anyway, but they could take on a lot more and be a lot more preemptive and take control of the health system, advocating for the person.
Yeah. What is one thing we can do to help the elderly at the end of life to have a good death?
Oh, wow, that's a difficult one. Look, it gets back to those things that are important to them, and each person's going to be different. But like it was a big lesson for me to learn that elderly people, it's not really the medical things that they're after, although that's what we inflict on them. It's more those other things like loneliness and feeling of self-worth and all those things. So it's a community thing. It's not a medical thing.
Yeah. One from Keith. How would we work towards this in Tasmania? Is there anywhere that is doing this better?
Not that I know of in Australia. I think that South Australia leads the game in this area. Queensland are also doing very well. But it's still not a comprehensive crossing the silos approach. I worked in Scandinavia for a while, and they seem to have been a little bit ahead of us in this way. And I think that's because they've got more aggressive society who sort of demand things from the system. Like if I could just mention here, birthing in the 60s and 70s was a medical event. So women were taken into hospital, all treated the same, baby taken off them, husbands not allowed there, baby put in a glass room. And then suddenly it all changed, and now women have control over their own birth. I don't think it was the doctors that did that. I think it was the women. So I think empowering society to have control over their own goals of care, but I don't know how you do this. Maybe we just talk about it a lot more articles, a lot more films, a lot less on medical miracles
Mm.
and more on what it means to get older and being honest about it.
So maybe it is almost a community awareness piece more than
Yes,
yeah, yeah.
yeah, no, absolutely.
Um, Question from Kate. If we allow people to stay in aged care homes to die, we need to provide them with all the resources and education. Oh, that's more of a statement. A question from Rachel. How can we change societal views that our elders are important? Our elders are important.
How do we change society's view on that?
Yes.
Oh,
Big question.
oh, that's a big question, isn't it? Maybe we've got something to learn from the Aboriginal community and other people like the Chinese who seem to sort of integrate the elderly much more than what we do. But I don't know how you do it. I don't know how you do it. I'll tell you what, I like television series and movies where the elderly do something outrageous in these homes, like they escape and rob banks, or they hijack buses and run all around the country. I like movies like that where you treat the elderly as human beings doing really great stuff,
Yeah, doing human things.
doing human things. Yeah.
Yeah. Um, do you have any suggestions on when treating medical teams in hospitals seem resistant to acknowledging patients who may be nearing the end of life and could benefit from palliative care input earlier rather than
Oh,
waiting until they are immediately dying?
look, I've almost given up with my medical colleagues. They're specialists in their own areas. They're brilliant. If you've got a single problem like a stent in the coronary artery, absolutely stunning. But we're so divided with medical specialization. I've come to think that we need to bypass them. Now, I don't think they'd mind that. I think that if we had a way of recognizing elderly people at the end of life, or indeed anyone at the end of life, and we talk to these teams and say, look, I know you're pressed for time. Do you want us to take over and do this? And then we'll always come back to you and tell you what we're doing. They would be happy with that. I
Mm.
think we've got to bypass them and put it in the hands of experts like palliative care people.
Um, in aged care, we tend to hear staff saying, for example, Mrs. Jones is now on palliative, which actually means Mrs. Jones is now on end of life care. How do we get the message out there uh, and the difference?
End of life care and palliative care. Yeah. Is that related to the word palliative care and the scariness that's associated with it? Do you think, Luke?
I think it can be. I think depending on people's understanding and knowledge of what palliative care it is, it can be quite
Yeah.
a taboo subject sometimes. Absolutely.
Yeah.
Absolutely.
Yeah. Maybe if we're just more honest about end of life and dying, and what would you want? To be more honest. But we're in an age of healthy aging, and it's almost taboo to be talking about end of life and dying and all that sorts of thing as you get older. Then of course you love these older people. They're your parents or your grandparents, so you don't want to hurt them, which is really patronizing, isn't it?
Mm. Question from Brad. We talk a lot about relying less on RACFs and the medical system. Is there a missing understanding in Australia on what is the legal or possible to be optional once an elderly person is considered frail?
A legal approach to that.
Yeah, so is there a missing understanding in Australia on what is legal or possible to be an option once an elderly person is considered frail?
Oh no, I definitely don't think it's a legal issue.
Mm,
I think it's the person issue. And if you're honest with what aging and frailty means, and it would lead to dying, but maybe not next week, maybe in 10 years' time or whatever, depending on your level of frailty, just to explain frailty in really honest terms. You've got to keep the lawyers out of this.
mm. Um, if we are lucky, we will get old. If we are lucky, we will get old, as we all know. Not everybody makes it. How can we be the next generation to hold our own destiny?
Um, I think it's a matter of empowering people. You see, I think we've done so many miraculous things in medicine that we've taken choice and power away from people. But working in this high technology end in intensive care, where I've got all these medical miracles, they're fantastic in certain groups of people, but they're totally inappropriate in other groups of people. So I think it's a matter of empowering people, of saying, look, medicine's great for some things, but it's not good for many, many things. You can't cure COVID, for example, or but you can be honest about what it means and what could happen afterwards with long COVID. I think it's just a matter of empowering people in a more honest way about health issues.
Yeah, agreed. How do you see carers fitting into a model of making sure the elderly wishes are fulfilled?
Yeah, carers is a whole nother problem, isn't it? Because our society tends to dump a lot on carers. And I think we need to support carers a lot more than what we do. They need to be included in whatever system we have. And that system is probably going to move towards dying in the home a lot more. But in order to do that, we need to make sure that we don't isolate the carer in the house, that they get respite care and support and all sorts of things. Yeah.
Question from Sarah. How can we better support older, frail people to live at home where they want to be, including getting them home quicker if they do end up in hospital, where the odds are they will decondition further?
Absolutely. Look, I spend $5,000 per patient per day in the ICU. So imagine what you could do in the home for $5,000. You give a person $5,000, you could have 24-hour, service with whatever meals you want, 3 or 4 nurses, each shift 24 hours a day, whatever. So I think it's a matter of moving towards care in the home. I think that's a superb idea, but you need to fund it and you need to support people to be in the home, especially the carers.
Mm. Question from Keith. Your thoughts for frailty to be allowed to access VAD or voluntary assisted dying?
Ah, good point. Good point. If you have terminal cancer, then we're allowed to talk about voluntary assisted dying. But if you've got terminal elderly old age and you've only got a couple of months to live, then we're not allowed to talk about voluntary assisted dying. Now that is interesting because the data is just as strong with uncertainty. So if you've got a terminal brain cancer, then the person would say, well, how long I've got to live? And you'd say 3 months. Now, it could be 6 months, it could be 1 year, it could be 2 weeks, whatever. So there's inherent uncertainty. And just because there's inherent uncertainty doesn't mean we shouldn't discuss the issue. So I can see a time where the elderly, near the end of life, as defined by the data we have, will be eligible for voluntary assisted dying. I don't know. How do you feel about that, Luke?
I mean, I think the position that I have is everyone is entitled to everyone is entitled to their own pathway. And I think It's somewhat difficult with different states having different regulation for that and what that looks like. But I think from the conversations that I've had with the VAD team in Tasmania, it is definitely progressing in the right way, definitely taking the right steps, and the system is it's being built, continue to, I think, be improved, and yeah, I think the model itself is improving as it sort of grows.
Yeah. Yeah.
Um, Question from Colleen: how can the government be convinced to redirect funds for dying at home? Probably piggybacking off the question that was asked previously.
Well, no, that's interesting. I don't think politicians like talking about dying and death. There are all sorts of no-go issues in there. But I think as we become more honest in our society, then they'll see not only benefits for the person who wants to die at home, but they'll see enormous economic advantages. Because at the moment, our hospitals are full of elderly, frail people near the end of life, which means you can't do elective surgery, ED overcrowding, hospital beds needing upgrading, ambulance ramping. So this is a win-win situation, isn't it? It's not where people want to go to die, and it's certainly costing a fortune. So as soon as we make it easier for politicians to accept talking about death and dying, the better.
Have you seen a situation where that's happened, like in another state or another country, where the government has sort of acknowledged the benefit of that? Is there any
Yeah,
example you can think of?
yeah. Look, it happened in Sweden when I was working there. That they're much more honest about it, and they talk about this is in the person's interest. This is what the person wants, and if you stick to that rather than this will save money,
Mm.
I think that's the way to go. If you say we're going to boot a whole lot of elderly people out because it's costing too much, you've got no hope.
Mm.
So so you do it in the person's interest, but the economic benefit follows.
Yeah. Yeah. They kind of go hand in hand by the sounds of it.
Yeah.
Great. I'm just seeing if we've got any other questions that are flowing through. I think that might, there's some really great comments, and I'll pass some of these on to you, Kenneth. Some people will
Yeah.
make some really great points and statements that I'm sure that you'd find interesting. So I'll make sure I'll pass them on to
Thanks.
Ken. But I think that might wrap up our Q&A session. So thank you everyone for participating in tracking your questions in, and thank you, Ken, for taking the time to answer them. Really appreciate it. Just before we all depart, I'd just like to extend a special thank you to our PCT members. So thank you for joining us. If you enjoyed today's event, the best way you can stay connected with Palliative Care Tasmania is to become a member. The recording of this session, along with a few of our other speaker series, will be made available to our PCT members. If you'd like to join us, scan the QR code or visit our website to join today. It's a pretty simple process. Normally takes about 5 minutes to sign up. And thank you all for joining us for today's speaker series. We appreciate your participation, and hope you all found the session really valuable. If you could take a few moments just to complete the survey, your feedback helps us to continue to provide valuable events and speakers, such as Professor Ken. You can access the survey via the follow-up email you will receive at the end of today's session, or by scanning the QR code, which is on the screen at the moment. And I hope we see you all at our next speaker series session with Dr. Megan Hanley, which is on the 1st of August. The nature of the topics we do discuss can sometimes raise complex and powerful raw emotions. So I encourage you all to keep checking in with yourself today. I hope you all have a lovely day, and thank you all again, and Ken, for joining us in.
Thank you.